All right. So a very good afternoon to all of you. So today we'll be discussing drugs in plasma cell neoplasms. So this is 14th session of our series, and we've been doing this drugs for the solid tumors first, and now we are in the hemat section. And today we have some stellar faculty with us and a dynamic speaker. So for today's program, our program director is Dr. Pravas Mishra, sir. Sir is a consultant at Amrita, Faridabad. Dishank, can we have the slide?
It's all right. We can move forward.
Dishank,
Hello.
so just a second, I think there's a glitch.
No,
Uh,
that's all right.
so over to you, sir.
Yeah, good afternoon, Karan. Good afternoon, everyone. So, welcome to this drugs and plasma cell neoplasms uh, part in the web series. I will now introduce Dr. Uday, who is a professor of hematology at AFMC. He will be taking over as the moderator of this session. Over to you, Uday.
Thank you, Pravas, sir. Firstly, I'm really very delighted to be part of this E-Gurukul session. This is my first of the interaction with E-Gurukul. But the way the whole thing has been planned and charted out, I'm really excited to go through this whole exercise, academic exercise. So today we are going to discuss about the drugs in myeloma or in the plasma cell neoplasms. As we all understand, myeloma is a very common disorder. It, in fact, is rated as the third common hematological malignancy. And the armamentarium is increasing day by day. Around 2 decades back, where we just had 2 drugs to manage, now we almost have around 14 drugs available in Indian markets to manage. And we are moving from treatment to cure in multiple myeloma with the availability of the newer drugs. So with that introduction, I would like to request Dr. Nihanthy, who happens to be a seasoned oncologist from West Bengal, Calcutta, who has got trained in multiple league institutes across the country to explain the students or the people who are attending the session about the various nuances of managing myeloma, particularly the nuances related to the drug administration. So over to Dr. Nihanthy for taking it further.
Good afternoon, everyone. I thank Dr. Uday sir for such warm welcome. First of all, before starting, I want to thank the E-Gurukul series for giving me an opportunity to talk about the drugs used in the plasma cell disorder. I want to thank Parvez sir, Uday sir, Pankaj sir for immensely supporting me, and our coordinator, Karan, for being so kind. Special thanks to Hamza sir for being kind enough and solving all my queries throughout. So I'll be sharing my screen. So is it visible?
Yes, ma'am, it's visible and you're audible.
Okay, thank you, Karan. Once again, I thank E-Gurukul and everyone for giving me a wonderful opportunity and all my mentors for this session. Thank you. So with this, we'll be starting with the class. So I just want to explain the best example of multiple myeloma is it has been both an ancient disease and a modern disease. Why so? Let's look into the glimpse of it. Actually, the first glimpse starts from around 1844 when Henry Benz-Jones found out about this protein. So there was immense research about this protein which was found in a urine of a patient. But till 20th century, even though they understood the protein was being secreted by a cell, the in-depth knowledge about the plasma cell came around the 20th century. Then came the era of 1940s to 1990s, maybe the World War and the steroids and the alkylators came in play. And finally, the era of revolution began. So this is a brief intro of the revolution, how with a single drug we came to doublet, triplet, and now we are in an era of a quadruplet, along with ADCs and all the CAR-T therapy. So this is just a gist which the students can go through later. So just a brief about how the treatment can be divided. We are going to divide into transplant eligible and ineligible. Based on the cytogenetics, a standard risk given the VRD, early transplant, or in a high risk, a quadruplet regimen based on the affordability again. And finally, the maintenance is being given. So my entire presentation, I would be getting into 2 sections. How are they going to go? One is, if you look into the plasma cell especially, so here I just want to zoom in. I hope it's quite clear. So we are dividing into two sections. One, the targeting the multiple myeloma, the cell variabilities. So if you actually look into the multiple myeloma cells, we know that it produces various proteins. Now, these are the proteins which are present, changes the epigenetics, changes the clonal dependency, various interleukins, interferons, everything is released. So with this, we got the drugs which target these ones. That's like proteasome inhibitor, HDAC inhibitors, and various other epidrugs can be also being present. And the second section will be focusing mainly on the tumor microenvironment. So this is the most topic which is very well spoken regarding the tumor immunology. So just a brief about the tumor microenvironment. These various drugs which are being present, they're trying to change the tumor immunity along with the environment in which the plasma cells, the one which was supposedly sustaining, can be inhibited by various drugs like IMiDs, antibody conjugates, the BiTEs, and finally the CAR T cell. So the main drugs would be focused on our alkylating agents would be discussed in a stem cell transplant class. So I would be focusing mainly on proteasome inhibitors. That is the bortezomib, carfilzomib. Others are the IMiDs, which is the thalidomide, len, and the pomalidomide, nuclear export selinexor, HDAC inhibitors, and the monoclonal antibodies. So with this first drug, which I would start is the proteasome inhibitor, which has been the backbone for multiple myeloma treatment. So how does this act? So if you look into this picture, so we all know that this I want to focus. Best example of tumor immunology is multiple myeloma. So you try understanding the concept like how the proteins are produced, how it's going to act. And if you're trying to inhibit this mechanism, this leads your mechanism of action of all your drugs. And by looking into the specific target and off target, the toxicity can be tolerated. So here, proteasome inhibitor, most of the plasma cells which are present, they have very high affinity for the bone marrow stromal cell because of VCAM addition molecules. And we also know that they undergo various epigenetics and various other alteration pathway. What does this proteasome inhibitors do? They mainly cause deregulation of proteins, leading to various injury in the mitochondria, endoplasmic reticulums, and various other stress-related proteins are being produced. So what are the ends of this? Mainly this increases the apoptotic pathways. That can be both extracellular, intracellular, based on the caspase 8 or 3. Various reactivating species are being produced. So end of the day, what does this do is they're trying to degrade the protein, the chaperones which are being present, increasing the stress, finally leading to cell death by apoptosis. So various generations which we have 3 generations. Gen 1 is the bortezomib, generation 2 is the carfilzomib, and 3 is the ixazomib. Just the key differences is the Gen 1 is reversible, whereas the other 2 are irreversible. But we need to know into the toxicity per se also. So coming to each and every single drug, first is the bortezomib, called as Velcat. How do we get it? It's a 3.5 mg lyophilized powder. And the dosing which we use is 1.3 mg per meter square. Either the route can be intravenous or the subcutaneous, twice weekly dosing. Alternatively, again, for some patients, we do once in a week dosing also. Dose adjustment is only required in case of severe renal liver impairment. So if you look into two things, there is a person with a peripheral neuropathy. Which form of modality do you want to use? In those cases, subcut is very important because the proteasome inhibitor acts as an axonal degeneration. And then because of which the subcutaneous part deposition becomes less, as a result of which the incidence of peripheral neuropathy becomes less. The other adverse reactions which are more common are the common side effects, and the low blood counts can also be seen. The important point which has to be kept whenever we are giving a proteasome inhibitor is reactivation of herpes zoster. Thus, all the patients have to be undergoing a prophylaxis for herpes zoster by acyclovir. Other things like look at for monitoring of WBCs, any increased risk of other infections. Some institutes even follow antivirals and antibacterial also. Even this prophylaxis can be taken care. Most important is hypersensitivity. Why? Whenever we are trying to alter any protein, the most form of toxicity which we see is the various interleukins and interferons which are produced, leading to allergic reaction. Whenever a patient reports, it's good to discontinue this drug. The second is the carfilzomib. Again, this is 60 mg lyophilized powder, dosing of 20 mg per meter square day 1, 2, or even a weekly dose with 70 mg per meter square can be done. Again, an IV infusion of 10 to 30 minutes. One important thing to be kept into mind is Hydration is mandatory for all patients. So a prior thorough cardiac evaluation is mandatory. If a patient is having any issues of congestive heart failure or anything pertaining to hypertension, it's good either under supervision or better to avoid this drug. And other risk is this increased risk of clotting because various agglutination factors are altered. So we even give a prophylaxis. Others one can be like pulmonary toxicity, kidney and infusion reaction. I'll be discussing mainly the important ones because there are a lot of drugs and I need to cover in a limited time. So the third gen one which has been present is ixazomib. This is the first oral proteasome inhibitor, which is a 4 mg dosage. Again, based on the creat clearance, we may start with a lower dose. If patient is tolerating, we can increase. Most important class side effect is GI toxicity. Why so? Because of its CYP3A inducers. So it's better advisable if the patient takes in an empty stomach. And it's also important to avoid high fat diet because absorption increases, there's increase in toxicity, especially like arrhythmias. Same, all IMiDs and all proteasome inhibitors have increased thrombosis risk. So this has to be kept into consideration. So we are going to the next class of drugs, that is the immunomodulatory. So again, I just want to explain briefly about the mechanism of action. As we all know that plasma cell is a best example of how they adapt to tumor microenvironment. So our main aim is, let it be the angiogenesis or whatever pro-apoptotic factors which multiple myeloma cells are producing, we have to inhibit them. So the mechanism of action of the IMiDs are basically, they boost the T cell and the NK cell activity. So what does this do? Mainly inhibiting the angiogenesis. Multiple myeloma, and especially the plasma cell, produces proteins called the Icaros and the Elios proteins. Why these proteins are very important? Because they change the VEGF pathways, TGF, various interleukins and all are produced, causing resistance of a myeloma cell to the therapy which we are implementing. So that is the reason we're trying to degrade these proteins and causes apoptosis. The main outcome of whatever drug we are using is apoptosis. So the key IMiDs are the thalidomide of first generation, len second. Thal had its own complications, which I'll be explaining. Len is somehow it's much better tolerated, and pomalidomide is mostly used in a relapsed refractory setting after an exposure with lenalidomide. So coming to thalidomide, it's a capsule form, 100 mg. Standard dose varies from 100 to 200. Better taken with water. Try avoiding all the fruit juices and especially high fat meal because of increased absorption. One thing, whenever a patient is on any of the IMiDs, they have side effects either like drowsiness, dizziness, constipation. Why? Drowsiness is because the IMiDs interact with the GABA pathways. So whenever the interaction happens, the sensorium depression occurs. Dizziness is because of the vascular tone. So they act on the vascular tone, causing all of a sudden a sympathetic and a parasympathetic activity, leading to hypotension and leading to dizziness. The other important side effect is constipation. So again, this comes because of a smooth muscle tone reduction. So whenever these tones are reduced, it's always advised to give either a prophylaxis, tell the patient not to stand immediately, getting out of the bed, not to drive, and avoid all other activities. Other class side effects are peripheral neuropathy. All these proteasome inhibitors, IMiDs, have an increased risk for infection. So always important that give a prophylactic doses of antivirals like acyclovir, antibacterial Ceptron double strength can be used, and even antifungal fluconazole, maybe a weekly once dosing or an institution-based protocol can be followed. There's an increased risk of clotting. So all these patients have to be subjected like a prophylactic dose or at least 6 months maintenance. Even on maintenance therapy, they have to be continued with all the anticoagulants. Peripheral neuropathy, monitoring the numbness, tingling sensation is quite important. Next comes the dose len, which is 25 mg. Strength is being given, either once daily dosing. Most importantly is lenalidomide can also be used in patients with who are end-stage renal disease on dialysis, but just the dose is reduced. So the dose adjustment varies on creat clearance because of its renal excretion. Again, the same common side effects, but neutropenia is more common in lenalidomide than neuropathy. So this has to be taken care. Infections are higher in len compared to thal. Most importantly is all these IMiDs are highly teratogenic. So if a young patient who's planning to conceive, it's always good to avoid pregnancy during this period. And yes, high clot risk need anticoagulation. And alcohol, as we already know, there is an interaction with the GABA system. So it's better to avoid all this. And finally, coming to pomalidomide, which is a 4 mg oral drug being given from day 1 to day 21 of 28-day cycle. Most important is, even in case of a renal impaired patient, doesn't require any dose consistency. Only in case of hepatic, a mild reduction is mandatory. Again, with the same class effects. Most important of this is there is again one thing called hypothyroidism, which is common in this compared to other two. A brief note on HDAC inhibitors. How does this act? I am not going in detail with this, but end of the day, the main thing is we are trying to inhibit the proteasome inhibitors or whatever IMiDs or whatever drugs we are using changes the entire protein mechanism of the multiple myeloma plasma cells which have been present. So HDAC inhibitors causes gene acetylation, induce apoptosis. End of the day, it's a cell death. The best example is panabinostat. But currently, the use of this comes in a very later lines, only in case of very relapsed, refractory, post multiple lines, and in highly drug resistant cases only. So it's an oral capsule, 10 to 20 mg strength is available. And the most important, don't crush or chew this medication because for a good bioavailability, a whole swallowing of capsule is mandatory. The one important is diarrhea. Other class effects are the same as other ones. So now let's focus on this section. What are the newer emerging treatments in multiple myeloma? So we all know we are in the era of immunotherapy. How can we change our treatment per se? One are the B-cell maturation antigen. This is basically with your CAR therapy or the bispecific antibodies. Other comes the G protein couple, which are bispecific antibodies, BiTE therapy. Others are the X proteins, BCL2 inhibitors, venetoclax. I won't go in detail regarding that as it's been discussed in the previous CLL classes. And finally, the CD38 monoclonal antibodies also. So first coming to the mechanism of monoclonal antibodies. I'm so sorry, I'm not able to zoom this slide. Yeah. So if you look into the mechanism of action, see, once you understand the mechanism of action, you'll understand the toxicity profile and you'll know how to prevent the toxicity too. So here, if you come into monoclonal antibodies, we have two drugs. One is a daratumab and ixatuzumab, which is acting on CD38, and elotuzumab, which is a SLAM7. So what is the CD38? This is basically a protein highly found only in plasma cells, because of which the toxicity per se is very less. The off-target reaction is quite less. So again, this activates the ADC antibody-dependent pathway mechanism. End of the day, it's angiogenesis, inhibition, and apoptosis. So, but how the complement-mediated pathway gets activated is important. There'll be one more class on tumor immunology, which will be conducted by the NBE. So, a detailed tumor immunology will be discussed in that. This is just a brief note. So, know that there is an antibody-dependent cells or an immunoglobulins which are being present, activating the ADC complex and the antibody-dependent cell toxicity or a complement-mediated pathway gets activated. So the drugs are the daratumab, CD38, even ixatuzumab, and elotuzumab, which is a SLAM7 inhibitor. So coming to daratumab, the strength are 100 mg, injections are available. And the dosages, there are two ways, either IV, subcut. IV, it's 16 mg per kg, or a subcutaneous one varies from 1800 mcg, week 1 to week 8. And again, we can change the dose, and there's a difference in the maintenance dose. The most important thing to be kept into consideration before administration is anaphylaxis. So steroids, antihistamines, antipyretics, and it's quite painful. So whenever you inject, patient complains of fever, chills, rigor. So it's very important that you give a whole good coverage, especially with antihistamines is mandatory. Other toxicity reactions are like fatigue. So post giving this, a patient complains of fatigue or any myalgia, it's mainly because of the daratumab complex, because you're targeting the CD38 substrate. So warning and precautions are infusion reactions. And all these will definitely have infection. So please continue all the prophylactic antibodies. One most important point to be kept whenever a CD38 monoclonal antibody is administered is the blood. Most of these patients post-administration may have anemia or anemia induced because of chemotherapy. So whenever a patient is on CD38 monoclonal antibody, you have to alert the labs, because what happens is the cross-matching becomes difficult. Why so? whenever a patient, the CD38 is usually present in the plasma cells. So as per se, on the patient's red blood cells, this is not present. It's present in a very lower minimal quantity. But the CD38, which has been present in the serum of the patient, starts reacting with the donor red blood cells, because of which there is pan-agglutination. So as a result of which your blood bank, all of a sudden they call up and they say that none of the blood group is matching to this patient. So how are you going to work on it? First, alarm the blood bank that the patient is on CD38 monoclonal antibody. Then the blood bank, what do? There is a chemical substance called DTT, that is dithiothetrol. What does this do? This basically breaks the bond, that is the disulfide bond of the CD38 antibody with the donor PRBCs. So because of this breakage, the agglutination is taken care of. But the disadvantage whenever you give a DTT is, there is even lysis of something called KEL antigen. So now what is this KEL antigen? There are some two things called KEL antigen and Kellen antigens. So why are these important? Similar like ABO blood grouping, this is again a different set of blood grouping which is involved. So a person who is KEL negative, if he gets a KEL positive blood, again there is a cross reaction leading to hemolysis and various severe life-threatening reactions, including hemolytic anemias. Sometimes even death is reported. So it's very important for us to tell the lab that we need a KEL negative blood, not a KEL positive. So whenever you are giving a patient on CD38, either collect the patient's blood prior or inform the labs regarding the CD38 monoclonal antibody usage. And important one is again hepatitis B reactivation. So end of the day, whatever drugs we are using in plasma cell disorder, all these causes immunosuppression. So it's very mandatory, and along with bortezomib also, it's very important that all a thorough viral serology has to be sent. Patient is found to be positive, first treat the cause and then maybe start with this. So coming to next one, ixatizumab, similar to that of daratumab, dosing is 10 mg per kg and the dosing can vary again onwards. Again, this has same fatigue, nausea, vomiting. The important point here is infusion reactions are higher. And most importantly, this something mimics like ICANS or CRS, which I'll be explaining in detail. Prophylaxis mandatory. Inform your lab about the CD38 treatment the patient is on. So coming to elotuzumab, what is this? This is a SLAM inhibitor that's basically acting the signaling lymphocyte activation molecule. I'm so sorry for the mistake which has happened here. The induction phase is 10 mg and the maintenance is again 10 mg per kg IV for every 2 weekly. All these medicines require good coverage with antihistamines and antipyretics. And maybe again, this also leads to various infusion reactions, low blood counts. And the main class reaction can also be seen as ILD. Like in other two things, we didn't have any pulmonary toxicity reported, but here there's an increase in the pulmonary toxicity. So with this, we are going to move to the next one, which is the B cell maturation. That is the BCMA targeted therapies. So what is this BCMA actually? The BCMA is also protein which has been present on the myeloma cells. The plasma cells are the best example of how a tumor resistance can develop, and the tumor is so smart that it can change its entire pathway of mutation, as a result leading to even resistance in the treatment which we are going to offer. So this BCMA is one of the important substrate of the plasma cell. So we are going to target this by either using an ADC complex or by using CART. And we are trying to break this, as a result of which increasing the tumor immunity by acting on the tumor immune cells and thus causing lysis. So the best example of ADC is belantamab mafodotin. Chimeric therapies I'll be explaining in detail. So first coming to this ADC, which is the belantamab mafodotin. What is this actually? So the best example which we can give is something like you're launching a satellite into space. So you need a vehicle. The vehicle is actually a rocket. Let it be a GSLV or a PSLV. Once it gets into the outer space, it separates and the satellite is launched. The similar mechanism of action happens with even the belantamab mafodotin also. Here, the payload which has been present is a monomethyl ornithine F. Why is this important? Because prior to administration of this drug, each and every patient should undergo a thorough eye examination. Why so? Because this MMFA, which has been present, monomethyl ornithine F, which has been present, It has a component called microtubule destabilizer, which starts acting on the corneal epithelium. Why corneal epithelium? Because cornea is one rapidly dividing one. So this acts on that, as a result of which causing lysis of the epithelium being present on the cornea. As a result of which, a patient who's already diabetic or having any previous issue, the toxicity has just becomes too overwhelming and leading to even corneal damage and keratopathy. Thus, a slit lamp and a visual acuity examination is very important. The strength is 100 mg lyophilized powder, and the dosing is 2.5 mg per kg IV infusion, which is given every 30 minutes over 3-week period. Pre-medication, definitely steroid eye drop, artificial tear, because the keratitis is so bad that your patient might just come and complain saying that, they just want to stop it. So it's better to avoid the toxicity by knowing the mechanism of action. Others are like thrombocytopenia. All these monoclonal antibodies, ADC, or even including the CAR therapies have high infusion reactions. So this has to be taken care. One important benefit is this can be given even in pregnant women, whereas in other drugs, which are very toxic, this doesn't harm the fetus. So this is one of the important, you can say, the implications that even in case of a pregnant woman or a woman who wants pregnancy to be planned, this is a drug which can be advised. So coming to one of the favorite topics called the CAR-T therapy. So how does this act? Basically, the BCMA substrate, this is the substrate we already know. We know the mechanism of action. So we need a substance which starts increasing this activity. So that's the antigen chimeric cells are attached to this substrate. So what does this do? The various mechanism is we have CARs which have the BCMA CARs attached to it, genetically engineered, and then they are injected into the patient's body after a lymphodepleted state. So this is just an example, like how the classification and the division of what are the, if you look into the structure of a CAR, the CAR is just similar to like you can say a immunoglobulin, which has a light chain and a heavy chain. There will be an antigen binding domain. Then there's an hinge region. This is into the extracellular part, and there's an intracellular. The intracellular can again have various co-stimulation. Why this various co-stimulation is based on this, the cards have been changed into generation. So if we look into this picture, we know there is some vintage molecule and there is a higher end molecule. So the first generation card has only one of a co-stimulatory molecule, that was a zeta signaling domain. So what is the signaling domain is? It's something like immune activations within the patient's own body and causing cell lysis. It's something similar to our immunotherapy mechanism of action. Then they came the second generation where CD228 was binded to it, increasing further activity. Then they came the third one where a 4-1BB complex also was added to it. Finally, the fourth generation are the armored cards. What are these armored cards is? We do have a substance which even targets something called a cytokine transgene. So this gets integrated within the CAR and also integrates it in the patient, changing the entire human immuno-microenvironment and leading to increased cell lysis. Finally, the thing is, it's a cell death. So from Gen 1, 2, 3, which is already approved, fourth is yet because it's still in clinical trial. So maybe the approval will be quite soon. So this is just the process of how to obtain it. So we all know, most importantly, whenever you're subjecting a patient for CAR-T, we all know that maybe in ALL, AML, CAR-T, and even lymphomas, the CAR-T is used quite prior. But in myeloma, we have so many drug options. That's the reason the CAR-T is pushed a bit backward. But what is the process of that is? Before selecting any patient for CAR therapy, life expectancy is mandatory. Anyone you know that who can live more than 12 weeks. This is what the guideline says. Very good performance status. Why this is important is you take a poor performance status patient, toxicity is quite high, like let it be the CRS or the ICANS. So how do we collect it? So we take the patient's healthy donor cells, then a genetically engineered chimeric card along with the BCMA component is attached to it. We subject the patient for a lymphodepleted state by giving a very high dose chemo, example like busulfan or institution-based protocol. Once in between, if there's a lot of delay, the patient can also be subjected for chemotherapy, like how we do in lymphomas. If the delay is not there, then directly the infusion of the chimeric products can be happening. So this is just a figure which again depicts that how the BCMA CAR-T is different from the normal CAR-T. Here, basically, if you look into the extracellular and the intracellular domain, along with the co-stimulatory molecule, we have an anti-BCMA component. So the main aim of ours is we're targeting which is highly specific. Like we all know these are on targets. these are not off target. So the difference between an on and off target is they are very cell specific. So this doesn't act anywhere else. If you consider an off target once, even the toxicity per se will become very less. So this, along with the binding of O1BB, along with the zeta, there's increase enhance activity. So now coming to the card, which is BCMA bounded, we have the idacaptogen, beclelucil. So the dose is something similar like how we take in transplant. We do have around, this is the quoted guidelines by the American Association, around 300 to 416 to 10 to the power of 6 CAR-T positive cells in a single infusion bag. We must be thinking that, oh my God, so many cells, the quantity is huge. No, the quantity is not that. It depends upon the collection. It varies from even 10 ml to 50 to 100 ml. It depends on how well you're able to collect it, how well are you able to generate it, store it, and then infuse it. So the volume is not important here. So you do a lymphodepletion state. After that, the administration happens. Most important things to be kept into consideration, which I'll be explaining, that is the CRS and the ICANS. Others are infection and secondary malignancies too. So if you look into the toxicity, the similar example, like how my guide, Brigadier P. Suresh used to sell, immunotherapy, the toxicity is head to toe, you add itis and you get a toxicity. CART also has a similar thing. It's from head to toe. So you can get anything from, transaminitis till that of nephritis. Everything is the same as that, which has been seen in immunotherapy. So what are the important toxicities, which is like alarming signs that is using in CAR-T are the CRS and the ICANS. So how do you distinguish when a patient is subjected to CAR, whether it's a CRS or an ICAN? This is just by various studies and how people have seen their patients and reported. So whenever a patient develops a high-grade fever or, myalgias or anything, this is mainly, it is because of CRS. CRS is usually seen from day 0. It actually starts from day 0 or day 1. ICAN usually happens a bit later, maybe somewhere at 4th or 5th day, or a bit, maybe even 7th day, but not earlier than that, because whatever the product you use has to go into the blood-brain barrier, penetrate them, and then cause an axonal degeneration. That is the reason ICANs are quite delayed compared to CRS. CRS is like immediately you inject, there is various interleukin TNFs released because of which patient has fever. That's the reason this is more acute compared to ICANs. But please don't mistake that patient can even have ICAN on day 1 also. But the clinical features are different. So this has to be kept into consideration whenever we are administering. Whenever we are giving a drug, it's very important to know the mechanism, what are the expected toxicity. As a good clinician, it's very important that you pick up the toxicity quite early, because if you pick the toxicity late, the outcomes are altered, leading to bad prognosis. Ultimately, sometimes ICANS and CRS can be so life-threatening that even death has been reported. So CRS, usually onset is 2 to 3 days, but it can be between 7 to 8 days also. So various inflammatory cells are released. There are various guidelines. There's one MSKCC adapted guidelines. There is an American cellular therapy guidelines, whichever one the institution can follow. The main thing is there is increased CRP, ferritin levels, interleukin 6 and 10. So patients can have, mostly it's like a flu symptom, high-grade fever. Sometimes even the markers can be less. Sometimes just because, markers can raise later. But still, you need to understand that if the patient is having any of the flu symptoms, suspect immediately post-infusion. And this, one more important thing is if the patient has high disease burden, performance status is poor, and age is quite higher, then patients can be, the incidence of CRS is quite high. So the American Society for Transplant and Cellular Therapy has given the scoring system and also grade 1 to grade 4. So it's something similar like how we do in other immunotherapies also. Important one is a good clinician is one who picks up main thing is you avoid toxicity, but some inevitable states, if you have toxicity, pick it up at earliest. So like you look into the fever, look into the pressures, and look into various clinical signs. So, if a patient is having CRS, the patient might have like tachycardia, later going to hypotension. So clinical signs and symptoms are very important. Bedside clinical examination. The basic is this. So maybe in grade 3, grade 4, pressors, and then a ventilatory support is also mandatory. So coming to the CRS management, we have various supportive drugs, that is the tocilizumab, common dosing from 4 mg per kg to 8 mg. So what does this mainly do is, whatever the chemicals, the interleukins, interferons, or even the TNF factors which have been reduced have been inhibited by this. If patient doesn't respond with this, initially even other drugs like steroids, methylpred, or even cyclophosphamide has been administered. Next, coming to ICANS. ICANS are very important because the patient usually, as we know that ICANS, the patient develop late, post-infusion, even if patient complains of a mild headache or there's a tremor, there's actually a scoring system. There is a proper questionnaire which is being given by MSTCC also. Like, the basic general question that did the patient take his food, or the patient is able to button his shirt, does the patient is able to recognize your name, his name, where is he staying? These are basic questionnaires. Whenever you give a CART infusion, immediately, maybe from the day onwards, day 0 onwards, this is being implemented. If there is scoring keeps increasing or anything, it's like an alarming sign. So we need to pick up immediately. Patient complains of mild headache, tremor, or even apraxia, aphasia. Please don't just wait. Subject the patient for investigations and start as soon as possible. Because if you don't pick up at an early state, there is high chances of mortality also. So again, there is the American Cellular Therapy group, which says that you need to look for the response. See, all this, whenever you're giving, what does it say is a good clinical response is mandatory. A bedside examination says that, okay, everything is okay, patient is off anything. If there is even a mild thing, just pick it up and you can avoid the serious complications or life-threatening complications can be avoided. So what are the managements? Again, there's a seizure prophylaxis. Steroid doses again can be tapered and altered based on this. And any interventions consider even in case of serious settings, cyclophosphamide. Some institutes, to avoid the CRS and the ICANS, they do give anakinra, which is an interleukin-1 antagonist, because it's quite expensive. So again, it varies from institution to institution. Some prefer even low-dose steroids. Again, this is a very controversial statement because some say use steroids and some say don't. So it's better to pick it up. Whenever you're giving, you know that you've administered something. There is this form of toxicity expected. A thorough clinical examination is mandatory in all these settings. Additional cytopenia, supportive care, measure the ferritin and look for any macrocyte activation syndromes, and antibiotic. A good high-end antibiotic coverage is mandatory. So now coming to the next classification of drug, these are bites. What are bites? Basically, there's two things you're holding together. One can be something like a CD3, which is targeting the T cell, and one can be something like a BCMA molecule, which is already present in the plasma cell. So you're targeting the BCMA, you're targeting the CD3, both combined together, causing lysis, mainly the lysis and activation of T cell component. So the best example of this mechanism of drug is elranatamab. These are the newer generation ones which I'm talking about. So this is the dosage form. It's an injection, 76 mg. So the administration is 12 mg and day 1 and the day 4 it's 32 mg. Most important whenever we are administering these forms, CRS and ICAN, others like anemia. In all these cases, darbepoetin or even like a prophylactic erythropoietin stimulant is also administered. And moreover, platelet count, like any of the growth supports can be given to patients prophylactically also. Most importantly, we need to check for neurotoxicity, because there's a high penetration into the blood-brain barrier, because of which elranatamab has increased ICANS compared to the other ones. Any hypersensitivity, we need to discontinue this further. And as it's excreted in the liver and the kidney, organ safety is mandatory. The next newer drug is talquetamab. The talquetamab, again, it's a bite one acting on the G-glycoprotein, which has been present along with the combination of CD3. All these mainly increases the immunity, mainly the tumor immunogenicity and causing lysis of that. So because of which, the dose which is given here is 0.01 mg per kg and maintenance dose can be 0.4. All these drugs require a strict pre-medication and antihistamine coverage. And moreover, all these drugs which have been present, one important thing I want to add on, the BCMA molecules are present highly in plasma cell. Where else it's present? It's actually present in the nails and the nail beds. So the patient can have skin and nail issues. So whenever some patient is coming, it looks like a fungal picture, but it's not because of any infection. It's mainly because of a drug induced. So all these things need to be kept into consideration. Other drugs, because they suppress our immunity, infection and infection prophylaxis is mandatory. So the next drug is the teclistamab. Teclistamab is again a BiTE, combination of the BCMA and the CD3. Dosage is 1.5 mg, which is being given once in a week for 4 weeks. Maintenance again varies. All this activates. Whenever you're giving a BCMA, it's very important to please note the nail changes also. The most important of this drug is cardiotoxicity. So any patient with the previous cardiac abnormalities, please avoid that because there is increased chances of arrhythmias, congestive heart failure, even death. ICAN, as we know that what are the precautions to be taken, and if present, pick it up early. If not, give as much as possible coverage with tocilizumab and other drugs like cyclophosphamide too. Now coming to another drug for the nuclear export inhibitors. The drug is the selinexor. So when are all these drugs used? It's actually used in case of in a relapsed and refractory post multiple lines. So the mechanism of action is as I told you, it's like, see, this is the picture which shows that basically the proteins which are being present are inhibited. Whatever the tumor, myeloma, plasma cell proteins are being secreted, the inhibition is by all these drugs. So leading to the apoptotic pathway activation. So the dosage is, strength is 20 mg, but the dosage which is given is 80 mg. It's very important that whenever we are taken, don't crush the tablet or chew the tablet. It has to be taken as a whole for good absorption and bioavailability. And yeah, most of the time, steroids I'm not covering in this class as it's already been mentioned. All the drugs are being given with steroids as the backbone. The common ones are fatigue, nausea, or vomiting. Others are, you need to check the WBC and RBC and platelets regularly. The one important thing is this increased risk of dizziness. This starts decreasing the vascular tone. So again, whenever and leading to falls and confusions and all, so patients have to be carefully alerted. It's better whenever a patient is taking all this, a small ID badge is made and you need to write that this is the drug the patient is on. So to make sure that, all of a sudden a wrong mismanagement is not happened. And importantly, dehydration. So fluid, encourage the patient to take as much as fluid. Again, if a patient is a known congestive heart failure, where the fluid restriction is mandatory, it's better to avoid in this setting. So other drugs which are used are the ALK and the BTK, which I won't be covering in this class, is just for the students to know that even these drugs can be used. But myeloma we have, because we know that tumor immunogenicity and we have so many targets, so maybe this comes way downwards. So coming to the maintenance therapy, based on the risk factor, the maintenance can depend like standard risk, THAL, LEN, or BOTI. Again, it's institution-based protocol. And high risk, we have the daratumab maintenance also, or a doublet combination can also be given. In some cases, we even use a triplet also. So just a small note on what is the resistance. So we all know that wherever the proteins are present, the chaperones or whatever, we are trying to target them. But the tumor is so smart that in spite of all this, they can undergo various epigenetic alteration. They change the ADC pathways, like, how the absorption was to happen. They change the entire transportation system, leading to abnormal drug transport. They start undergoing a genetic alteration within themselves. And the main aim is they want to live. So what do? Is they try escaping from various things, like either apoptosis or anti-angiogenesis factors and all. We also know the concept of cancer stem cell. So the one which becomes resistant starts proliferating and proliferating. So this resistant clone becomes bigger and bigger. Now we have other things called the tumor microenvironment. Like, you have the Tregs, or we have various things like, even the BCMA product which has been present on the myeloma cells starts changing their pathways, because of which they change the entire dynamics of the tumor and the penetrations of the drug. And other are the immunotherapy anti-agents which are formed. So all these things need to be kept into consideration, that whenever we are using any drug, the best thing is if there's a resistance with one drug, we can switch over. That's the best advantage in multiple myeloma. And our main aim would be for a PFS as we are looking for. But still all these mutations, alterations, drug resistance mechanism is important to kept into consideration. So there's a small brief note on what are the other supportive therapies. So as we all know that the myeloma cells which have been present, they have a high activity towards the bone marrow, because of various proteins which are being produced, like the DKK1 protein or multiple proteins, the VCAM addition molecules which are being present. So what does this do? The plasma cell starts getting deposited everywhere, and then they start eating up. That's a simpler way to explain, leading to lytic lesions. So mainly the blastic activity is reduced, increasing the clastic activity. Because of this misbalance, there is severe hypercalcemia in these patients. So all these things need to be kept into consideration whenever you're treating myeloma as a holistic disease. So these cells have high affinity to kidneys, they have high affinity towards the bones, bone marrow. So you need to focus on other parts also. So the best example for this is by giving bone disease management, either by the Ranke or the bisphosphonates. As we are focusing on the proteins or the immunity, the patient will always be immunosuppressed. So prophylactic antibiotics, antiviral, antifungal therapy are mandatory. And palliative care, because there is severe bone pain. The patient might just wake up in the night with crying bone pains. So it's very important. A good analgesic coverage, looking at the creat values is mandatory. Maybe even a palliative radiotherapy is recommended. And a good psychosocial support is indicated. So a brief note on the bone disease management. We do have various bisphosphonates. The drugs which are used are zoledronate and the pamidronate. And the other higher one is the Ranke ligand denosumab. If you look into both the comparison of the Ranke and the bisphosphonates, we exactly don't know how the bisphosphonates act. There is a hypothesis that they try inhibiting the osteoclastic activity, increasing the blastic activity. So leading to the lytic lesion gets changed to the sclerotic because of the calcium deposits which occurs. And even the calcium which was extracellular becomes intracellular, leading to even the hypercalcemic correction is also taken care. If you compare these two drugs, they do say that denosumab is much better than the bisphosphonates, no doubt of the skeletal related events, but affordability should be taken into consideration. But if a patient has, because we know that myeloma is a holistic disease with a lot of parameters getting affected, creat is important as the bisphosphonates is being excreted renally. So in case of CKD, it's better either go with the creat clearance or better to avoid. Other most important complications of all this are osteonecrosis. Before starting anything, it's better to get a thorough dental evaluation because the osteonecrosis of the jaw is so painful that the patient he won't complain of the disease, but he'll complain of the toxicity. So it's better to get a prophylactic dental evaluation done. And if there's anything, get it removed or cleaned or whatever the precautions are necessary. And only then, maybe after, if a procedure is done, after 4 weeks, we can start with these bisphosphonate regimens. Until then, if you want to target the bone pain, a good analgesics, opioids, or even a palliative RT can be taken into consideration. So with this, I would like to conclude with a few takeaways that we all know that how the evolution has happened in plasma cell and multiple myeloma treatment. We started with a single drug, steroids, and how during World War things changed. Finally came the image proteozyme, and then we started targeting even the resistance path, the CAR-T and the bispecific. If we look into the future and the next generation, maybe furthermore BCMA CARs or any CAR NK therapy, that is other important thing to be taken into consideration. Various other BCMA targeted therapy, which can reduce the ICANS a bit further. And most important is if P53 mutation is present, it is a high risk cytology. And most of the time patients end up having a resistance or to any of the drugs. So we can target this. Or maybe right now we all speak about how the AI driven or the CRISPR is important. So maybe all this can be implemented. So I would like to conclude by saying that we started with an old era. We came with a current drug. Later we went to the future one, focusing the ADCs and the CAR. Maybe in future more, we never know. We can target even the biomarker driven therapy, focusing the specific target, making it more precision medicine and reducing the toxicity for the patient. End of the day, we are trying to focusing and improving a good quality of care to the patient also. So with this, I want to conclude my talk. Thank you all.
Thanks a lot, Dr. Nihanthy. Can you hear me?
Yes, sir, I can hear you, sir.
So, sincere compliments for a great pedagogical clarity, the teaching with precision. So, happy to see you grow. I've seen you as a resident. Now I'm seeing you as a faculty and as a teacher today. So, really proud of you. So, just to introduce you to the others, she did her medical oncology from Army Hospital RNR, and she was our student from 2020 to 23. With that, I would open the session for any queries or questions from the audience. And if we do not have none, a few points, few snippets that I would like to definitely reiterate. One, we have some drugs, though which were not covered here, like thalidomide, cyclophosphamide, which bendamustine, which are still used by many of us. Regimens such as BTD PACE and DSEP are the drugs which can help us in those patients who have relapsed refractory situation, who cannot afford bites or CAR-T therapies. So we should not debunk the older regimens, number one. Number two, the reliance on steroids is gradually decreasing, though you rightly brought out it's a backbone. But the myeloma therapy is going towards steroid-free therapies. So that is the second thing that I wanted to bring out. Third, denosumab versus bisphosphonates. The studies really do not show a clear benefit of denosumab over bisphosphonates in general patients. There are specific indications like in patients with renal failure where it has definitely a role, but overall, otherwise the SRE effect on skeletal related events is more or less the same. We have a paper from Dr. Noopur, and she has given a 5-year follow-up recently, wherein she said that it really does not make a difference between the two. So both of them are more or less the same as far as the therapy is concerned. But yes, as you rightly brought out, finances needs to be considered, because in India, financial toxicity is one of the most important adverse event that we all face. So with that, I would like to invite comments and opinion from one of our most revered faculty, Pankaj Malhotra sir, who also happens to be the examiner for the next part of the talk. So for those, most of you must be knowing Pankaj sir. There is hardly would be anybody in the country who won't know Pankaj sir. But for the students, just a quick introduction. Pankaj sir is professor and head from Department of Clinical Hematology and Medical Oncology at PGI Chandigarh. So, sir has multiple accolades to his name, starting from ICMR fellowship to at Mayo Clinic to ICMLF award at Oregon Science and Health University in US. He has more than 461 publications, 20 chapters, and had supervised more than 108 MD, DM, and PhD theses. Anyway, this all put aside, we can say there are a generation of physicians and hematologists who trained under him, which itself speaks volumes more than any of his other achievements, who are doing really well across the world. So you will find students starting from Canada, US to India, to various parts of the country. He is otherwise a board member of the International Myeloma Society, and he is a representative, and he represents India in the International Myeloma Society. And so we are really proud of Sir being on the board. He is a founder president of the Indian Myeloma Academic Group, and he has been a key contributor to various guidelines on transplant, multiple myeloma across the national as well as international guidelines, and he plays a key role in national and international hematology research initiatives. So with that, I would like to hand over the stage to the next session, wherein Sir would be the examiner, and there will be 2 examinees, wherein Sir would be conducting the examination session for Dr. Santosh Kumar Swain and Dr. Pratibha Singh from Bhubaneswar and NRS Medical College, Kolkata. Over to you, Pankaj sir. So you can summarize or you can comment about anything that what Nihanthy has spoken about, and thereafter you can take on your examination session as well, sir.
Okay, thank you, Uday. Am I audible?
Yes,
Yes,
sir,
sir.
you're audible.
Okay. Thank you so much, Uday, for that introduction. And thank you to Karan, E-Gurukul, Nihanthy, who has extensively presented on different drugs which are used in multiple myeloma. In fact, it was quite extensive for last almost close to 40 minutes, 35 to 40 minutes. So I'm not sure, how much somebody had, understood the mechanism of action and all those things. What we are going to discuss is the commonly used drugs in the field of multiple myeloma, and what are the clinical points which we should look at that. I think we can go to the questions. Okay, so before this question, let me start with I see Pratibha and Santosh. So,
Yes, sir.
so Pratibha is in second year and Santosh is in first year,
Yes, sir.
or reverse.
No, sir, I'm
Sir, I'm finalist, sir.
Santosh, you are in final year.
Yes, sir.
Okay, so then the question goes to you. But before I ask this question, the drugs used contraindication in pregnancy. Let's start with the most commonly used drug previously, at least, was melphalan.
Thalidomide, sir.
No, before thalidomide, it was melphalan, prednisolone.
Yes, sir.
Before 2000, in fact, the regimens which were used was melphalan, prednisolone, and VAD regimen. Do you know what is VAD regimen? Any of you? VAD. Okay, so VAD regimen was the most common regimen which was used from almost 1980s till 2004 or 5. So V was vincristine, A was adriamycin, and D was dexamethasone. The VAD regimen was made by Dr. Bart Berlogi. Are you aware who is Bart Berlogi? Okay, Dr. Bart Berlogi is one of the most revered scientists in the field of multiple myeloma besides Robert Kyle. He was in MD Anderson Cancer Center where he made this regimen of VAD in 1980s. And then he moved to Arkansas where a research institute was made which was only dedicated to the field of multiple myeloma. There he started his therapies, which were called as total therapies, total therapy 1, total therapy 2, total therapy 3, and 4, because his aim was to cure myeloma. And he used all the available medicines to treat the myeloma at that time, from 1980s till almost 2003, 2004. And in the last 10 years or so, he has moved from Arkansas to New York with Dr. Sundar Jagannath. And I think now, currently, he is in the retirement mode. Any of you know what is total therapy?
No,
Have you heard of total therapy? Okay, total therapy was used in the field of acute lymphoblastic leukemia. So the drugs were the same. 1960s when we started treating acute lymphoblastic leukemia, vincristine, steroids, adriamycin. It was the sequence of drugs which helped in curability of acute lymphoblastic leukemia, especially in the childhood. So taking a cue from the treatment of acute lymphoblastic leukemia, Dr. Bart Berlogi started with the total therapies. He said probably we can also cure myeloma. And we are quite near to curing myeloma, although I feel it will take another maybe next decade or so, we would like to see a curability. So VAD regimen was vincristine, adriamycin, and dexamethasone, and the melphalan prednisolone. These were the two regimens which were used before 2000 for the treatment of myeloma. So have any of you used melphalan?
Yes, sir. In a patient who was not responding to multiple frontline therapies and was also not affordable for novel therapies, we, at the end of the day, resorted to melphalan-based therapy. We started him on melphalan in combination with steroid. Another option is that sometimes melphalan with thalidomide also we have given.
Okay, so what dose of melphalan did you use?
So melphalan, so we used it as per kg, sir. If I remember correctly, sir, I think it is 9 mg per kg. That is what we used.
Sir, for conditioning regimen, it is 200 milligram per meter square. For the BMP regimen, it is 9 milligram per meter square.
Yes, so the dose of melphalan is 9 milligram per meter square. And if you want to use per kg, then it is 0.025 milligram per kg per day. It is generally used 4 days a month because the action of it lasts for almost 4 to 6 weeks. So once you have used melphalan, you give only for 4 days. It is generally given empty stomach in the morning, whereas Dexa is given post meals. So, and the precautions which we need to take when we are giving melphalan is that it's excreted through the kidneys. So hence, if there is a renal failure which is present, then you have to use the half the dose. That means if you are using 9 milligram per meter square for 4 days, then you have to bring it down to 5 milligram per meter square or 4 milligram per meter square for 4 days. Or you can calculate the total dose, let's say 14 milligram or 15 milligram. You half the dose to 7 milligram or 8 milligram for use for 4 days. And the toxicity of melphalan is generally neutropenia, thrombocytopenia, or cytopenias. So you reevaluate the patient at 4 weeks, and if the cytopenias are still present, you can wait up to 6 weeks before giving the next course of melphalan prednisolone. So in the VAD regimen, since you have not heard of these things, so that's why I'm sharing the information with all the students and with you. In the VAD regimen, the dose of vincristine used was 0.4 milligram per day for 4 days. So in acute lymphoblastic leukemia, we use 1.4 mg per meter square weekly. But here the dose was 0.4 milligram, lower dose, and it was given in infusion. So when the VAD regimen was launched at that time, it was a 24-hour infusion of vincristine 0.4 milligram, right? And it is given for 4 days. So that means the total dose is 1.6 milligram per meter square, and it is given 4 days a month. The dose of adriamycin, so in the VAD regimen, it is VAD, so A is adriamycin. The dose of adriamycin was 9 milligram per meter square, again as a 24-hour infusion for 4 days. So that means total dose is 36 milligram per meter square. And the Dexa, which was given, was 40 milligram for 4 days. So then, people realized that a 24-hour infusion is quite difficult to give. So then people resorted it to bring it down from 24-hour to 4 hours. And then later on, some people said even 1 hour infusion is good enough. So these were the only regimens, melphalan prednisolone and VAD regimen, which were available to us before 2000. And then in 1999, and it's very interesting actually, thalidomide was available before 2000, and it was used for leprosy patients to take care of the lepra reaction, which happens after giving the therapy for leprosy. So thalidomide was available free of cost, even in India. It used to get imported from Germany. And then do you know who did the first work on thalidomide? Any of you?
Scientist.
Okay, it was Indian, Dr. Seema Singhal. So she was working with Dr. Bhat Barlogi in Arkansas. She and her husband, whose name is Jayesh Mehta. You should know about Jayesh Mehta as well as Seema Singhal. When the field of hematology before 1990s, there was a famous doctor by the name Dr. B.C. Mehta in Mumbai. Okay. So his work was mostly on iron deficiency anemia because that was what the hematology was in 1980s. And, there was not much of drugs in heme oncology at that time. So Dr. Jayesh Mehta is son of Dr. B.C. Mehta, and Dr. Seema Singhal is wife of Dr. Jayesh Mehta. So both were working initially on myeloma. So they were in Arkansas at that time. And uh, at that time, there was one cardiologist who got multiple myeloma, and And since there were not much therapies after melphalan, VED therapy, and transplant, so he was relapsed refractory, and his wife was searching for many of the therapies which can be used. And there was a scientist by the name Dr. Judah Folkman, who was working on immunogenesis. So Dr. Nihanthy discussed about how these IMiDs, thalidomide, lenalidomide, and pomalidomide, they are immunomodulatory drugs, right? So Dr. Judah Folkman was working on immunogenesis, and she somehow were able to contact Dr. Judah, and who said, you can try thalidomide, which is as such not available because of its teratogenic effect, but it is available for the lepra reaction, and you can try that. And now in USA, if you need to give any drug, you obviously need a permission. So the wife of the cardiologist went there. She actually initially went to Dr. Robert Kyle, who is the father of myeloma in Minnesota, in Mayo Clinic. He said, I won't be able to give, you go to Bart Burlogi. So she went to Bart Burlogi, who said, okay, we can try this. Thalidomide was tried, but that patient did not do well. The cardiologist did not do well, and he could not make it. But, at that time they said, okay, we can try to another patient, and they gave it to another patient who somehow responded to this thalidomide very well. And then they did the trial, which was published in New England Journal of Medicine in 1999, use of thalidomide in the treatment of myeloma. And at that time, there was so much of excitement for myeloma, for the treatment of myeloma, because you hardly had regimen. As I said before, you had only melphalan, and you have only VED. And immediately, as soon as thalidomide got approved, India, who was getting free thalidomide from Germany, immediately the supply was cut off and it was not available. In fact, one of my patients at that time actually went to Chennai, where this drug used to get imported from Germany, and he got admitted in the hospital where the patient with leprosy were getting treated to get hold of thalidomide. So you can imagine the kind of the kind of enthusiasm at that time, and he he went to Chennai also. So anyway, the major advantage of launching of thalidomide was because it opened up the drugs for all the IMiDs drugs. So you have thalidomide, and then you have lenalidomide, and you have pomalidomide. So when did lenalidomide launched? Any of you know about that?
So in 2003 or 5, I think, if I'm not wrong.
Yeah, 2005. So almost close to when bortezomib was launched. So both bortezomib and lenalidomide was almost launched simultaneously from bortezomib was launched in 2003 and lenalidomide in 2005. So when thalidomide came, Dr. Nihanthy mentioned the dose is 100 to 200 milligram, but we have used up to 800 milligram of thalidomide. So these days, the dose which is available is 50 milligram capsule, 100 milligram capsule. We start with 50 milligram, and then we go as whatever patient tolerates. So we start with 50 milligram in the night. Dr. Nihanthy mentioned about the side effects of thalidomide. So what are the side effects of thalidomide?
Sir, it was first used in the pregnancy and vomiting, so stopped due to the phecomalia. But it restarted in the myeloma, having the side effect generally it is the myelosuppressive. And the neuropathy sedation. This particular is the drugs specific for IMiD out of lenalidomide and pomalidomide is specific is neuropathy and sedation.
Sedation and neuropathy. Dr. Pratibha, anything else?
Yes, sir. Like ma'am mentioned, that it has an impact on the GABA receptor, so it causes a lot of sedation, and also patients are advised not to directly stand up. It can cause some level of hypotension also in them. In addition to that, it is myelosuppressive, to some extent, and gastrointestinal side effects are it causes constipation, very significant constipation. So these are the other side effects.
Yeah, I think you are right. So one is the constipation. So that's why you always start with 50 milligram in the night. Sedation, as has already been said. When it was launched in 1960s, uh, what was its use?
Sir, it was actually given in pregnant females for hyperemesis gravidarum.
Yes. So it is a very good drug to be used for nausea, vomiting at that time. So hyperemesis, and second in 1960s.
Sir, for used it for leprosy also.
No, at that time it was not used for the reactions. So it was a painkiller. They say it is as you mentioned, GABA receptors. It works on the GABA receptor. So it was a painkiller as well as it was used for hyperemesis at that time. So the side effects of thalidomide are sedation, constipation, and neuropathy. And what is the difference between the neuropathy of thalidomide versus bortezomib?
In sir, botulism it is the axonal degeneration. Botulism cause the axonal degeneration. It is the axonal neuropathy, and here it is motor neuropathy, sir.
Dr. Pratibha, anything?
So bortezomib is both sensory motor and thalidomide. Sir, I'm not very sure about the
Okay,
neuropathy.
so thalidomide, the neuropathy of both bortezomib and thalidomide are the same. The only difference is if the neuropathy happens because of thalidomide, it is irreversible. Whereas in bortezomib, it is reversible. So in bortezomib, you can decrease the dose of bortezomib, you can stop bortezomib, and to some extent, the neuropathy is reversible. Whereas if the neuropathy has happened because of thalidomide, it is irreversible. So that's why the its use actually has, not very much because of this toxicity. And as I mentioned before, the dose of thalidomide use was from 50 milligram to 100 to up to 800 milligram we have used in patients. So after the availability of thalidomide, the one of the treatment which is now has become the standard treatment is the use of triplet. So previously, before 2000, was kind of a doublet, melphalan, prednisolone, VAD regimen. So after the availability of thalidomide, people said, okay, you can use VAD with thalidomide, you can use melphalan, prednisolone with thalidomide. So then the effects of there was increase in the remission status of in the field of multiple myeloma. So, okay, I think there are some slides also, so we can use, now we can go to this question. Which drugs used in multiple myeloma? No, keep the first question. Which drugs used in multiple myeloma is contraindicated in pregnancy? Okay, so thalidomide we have already said. What are the other drugs which are contraindicated in pregnancy?
Lenalidomide and pomalidomide also are used with restrictive use, but bortezomib, to some extent, we can still use in pregnancy. So all immunomodulatory drugs, they are contraindicated in pregnancy.
Yeah, almost I would say all immunomodulatory drugs, as well as actually whatever drugs which are used in the field of multiple myeloma, except probably dexamethasone, are kind of used with caution in pregnancy. We hardly see any patient. The good
Pregnancy.
thing about myeloma is that mostly, the patients are above 40 years or 45 years of age. The average median age of patient is 60 to 65 years. So hardly any patient, you will see a pregnant patient with myeloma, but almost all drugs. And here I would like to, correct in the presentation by Dr. Nihanthy. She said belantamab can be used in pregnancy. I don't think so. Any of the antibody drug conjugates can be used in pregnancy. So, okay, now we can go to the next question too. Question two, please. Question 2. Yeah. In a patient on bortezomib therapy, which prophylactic medication is routinely recommended? Okay.
Sir, antiviral.
Which antiviral?
Sir, herpes, sir. Acyclovir we should give a 400 milligram BD or valcyclovir 500 OD.
Okay. And any other thing, Dr. Pratibha?
Yes, sir. Apart from that, sir, we also give the antithrombotic prophylaxis in our patients who are receiving these therapies in combination with steroids. So we can start them on aspirin, and along with that, sir, we also give them antibacterial prophylaxis like Cetran DS that is used. So antiviral, antibacterial, and antithrombotic prophylaxis.
Okay, let me ask you, let's say the patient is on maintenance bortezomib therapy. That means no steroids, no amides, only bortezomib. Would you give any prophylaxis to this patient?
Sir, in that case, sir, not an antithrombotic prophylaxis, but so because the disease biology is such, I think I will still continue the patient on this antiviral and antiviral prophylaxis and the antibacterial prophylaxis.
Okay, so herpes zoster prophylaxis is must if the patient is on bortezomib. And if generally we use acyclovir, which is 400 milligram twice daily, or valcyclovir, which is 500 milligram once a daily, as Dr. Santosh already said about that. Patients who have renal failure, you can modify the dose of acyclovir to 200 milligram twice daily instead of 400 milligram twice daily. Some people, let's say, if patient says, acyclovir is sometimes patients are not able to tolerate acyclovir. So let's say some patient says, or some patient develop reaction because of acyclovir or valcyclovir. What is the alternative?
Um, sir,
What else do we do to, let's say somebody who does not have multiple myeloma and uh, what are the risk factor for development of herpes zoster?
Sir, immunocompromised states like diabetes or any patient on immunosuppressive therapy or malignancy, these are the high risk factors to develop the herpes zoster
reactivation.
in the specific dermatome area.
Okay. So somebody has raised hand. Ajay Gupta, you want to say something? I don't know how to this word, whether they can say. Please type the things if you want to answer. So one of the things which is these days available is the vaccine for herpes zoster. Are you aware of the vaccine?
Yes, sir.
What vaccine is available? What is the other name of herpes zoster?
Sir, singles.
Shingles vaccine.
Shingles. Yeah,
They are giving.
so in the West, people don't say herpes zoster, they would say shingles. And the vaccine is available by the name of shingles vaccine, right? It is little costly, uh, close to, I think, 8,000 or 9,000 rupees per injection, and you have to give 2 dosages. So these days, people who are affordable, it is good idea to use shingles vaccine before the start of therapy. So before you start multiple myeloma therapy, you can consider giving shingles vaccine to the patient. Even though there is some controversy that people might say that the patient is already kind of immunocompromised because it is a plasma cell disorder and the antibody formation may not be adequate once you give the vaccination, but still, it will offer some protection. And in India, one of the thing is when you are asking the patient to continue with acyclovir or valcyclovir, patients would leave the medicine in between, and we have seen that even if the patients are on prophylaxis, they tend to develop herpes zoster. So it's a good idea to give a shingles vaccine to these patients who are affordable. Otherwise, patient on bortezomib have to continue on acyclovir or valcyclovir. Even after vaccination, actually, you might have to continue acyclovir or valcyclovir. The only advantage is that if the patients leave the medicine or skip the medicine, they are still protected about that. Okay. We, how do you prevent peripheral neuropathy in patients on bortezomib?
Sir, we switch to subcutaneous therapy, sir. If still subcutaneous therapy patient having the grade 1 without pain, we can still continue 1.3 milligram per meter square. If it is grade 1 with painful or grade 2, you can reduce the dose to 1 milligram per meter square. If it is grade 2 painful or grade 3, you can reduce it to 0.7 milligram per meter square. And
Okay,
subcutaneous.
Dr. Pratibha, you want to add something?
So these points only the dose modification as per the grading of the patient, peripheral neuropathy, and switching over to the subcutaneous mode of administration instead of IV. That has been very helpful in preventing peripheral neuropathy. Also, first of all, ruling out if the patient has a pre-existing condition in which he is having symptoms of peripheral neuropathy. So that also we need to take care of.
Any of you know what is the prevalence of neuropathy at the time of diagnosis of multiple myeloma? Newly diagnosed patients of multiple myeloma without diabetes, without anything, what is the prevalence of neuropathy?
No, sir, no idea.
So it is very interesting. We did this study long back, 2007 or 8, we published in Leukemia Lymphoma. And when we did the nerve conduction studies in all those patients at the time of diagnosis, we took the clinical uh, history. That means we asked about the history of numbness and tingling sensations and other things. And we also did the NCV studies. Almost close to 60% of patients, newly diagnosed patients of multiple myeloma, had some evidence of neuropathy. So we postulated at that time that myeloma itself can cause neuropathy in some of these patients. Although it was mostly grade 1, not grade 2 or grade 3. And somebody who is diabetic, obviously the chances of neuropathy are high. And that's why the when bortezomib came initially, when it was launched in 2003, the dose at that time, you would be surprised, was 1.6 milligram per meter square. And the regimen which was used was day 1, 4, 8, 11 of a 21-day cycle. Now, universally, for the last many years, we have now moved to 1.3 milligram per meter square. We have reduced the dose and we have also made it weekly. So we don't use anymore 1, 4, 8, 11. We used weekly regimen of 1.3 milligram per meter square. And we have stopped using IV. We have switched to subcutaneous use. Why to give IV unnecessarily when we know the incidence of neuropathy is high on use of IV dose? So we have used as a standard subcutaneous and we have used to weekly regimen. Now the question is, let's say you are having a round with the consultant and consultant here says, no, use 14811 bortezomib. Don't use weekly, use 14811. What is the situation where actually you would like to use the more frequent use of bortezomib? I already told you it is the standard to use weekly, it is standard to use subcutaneously. But let's say somebody says, no, use 1.6 milligram per meter square and use day 1, 4, 8, 11. Any situation in myeloma?
Sir, as per the disease burden, or if we are having an IgM disease, or we have any baseline risk factors, then we can go for a more aggressive approach.
You are a little bit right. So IgM myeloma is not there. IgM, if there it is there, it is Waldenstrom macroglobulinemia and not multiple myeloma. And patients who have renal failure. Renal failure is kind of an emergency, and so is the spinal cord compression. So there, in the spinal cord compression, most people use high-dose dexamethasone day 1 to day 4. But in patients with renal failure, you can use day 1, 4, 8, 11. And then the next cycle starts 10 days after the last dose of bortezomib, or it is a 21-day cycle and not a weekly cycle. So there is one situation where you can use a higher dose, where you can use a more frequent dose of bortezomib. Okay. Sorry. So the third question is already answered. What is the rationale for using bortezomib-based regimen in patients with renal failure? So I have already said. Can we go to the next slide? Okay, a patient on carfilzomib develops shortness of breath and lower limb swelling. What is the most likely cause?
Congestive heart failure due to carfilzomib.
Okay. Anything else, Dr. Pratibha?
So carfilzomib is notorious for causing cardiac toxicity. So first differential will be that only, and apart from that, short. So if the patient has there are some instances of pulmonary edema also associated with carfilzomib. So that can also, though it will not present with lower limb swelling, there will be shortness of breath and everything. So that can also be one of the cause, and um,
Okay, so these questions again, I acknowledge help of Dr. Nihanthy who has made this question, but let's say I would modify this question. So question remain the same. So it is a lower limb swelling, not lower limb swelling. So that means if there is a unilateral swelling of the limb and there is a shortness of breath,
Sir,
what is the
pulmonary
diagnosis?
embolism. The pulmonary embolism is the most common, sir.
Yeah, then it would be a DVT with pulmonary embolism, which obviously will take some time if the patient has received carfilzomib today. So it will take some time, but these patients can develop DVT, and that is why most patients are on prophylaxis, either with aspirin or with low molecular weight heparin or oral anticoagulation patients who are on anti-myeloma therapy. Okay, so how do we prevent this cardiotoxicity of carfilzomib?
um, sir, it is so patients who have a baseline cardiac dysfunction, it is not preferred in them, first of all. And like the dose we go for is quite high. So we reduce the dose which we give them uh, to 75% or to 50%. That is how we go ahead. If we have to use carfilzomib in that case.
Yes, correct. So obviously, whenever you are planning to do carfilzomib, always do a cardiac evaluation, which means ECG and echocardiography of these patients, and take the history of coronary heart disease. And echo is a must in these patients before you give carfilzomib. And the toxicity has also been seen if the patient is kind of a dehydrated. So
Hydration is very
you
important.
give the patient around 300 to 500 ml of normal saline before you give carfilzomib. Or if you don't want to give, let's say you really have to give and patient has some congestive heart failure and there is no alternative. So then you give very slow carfilzomib. Generally, it is given in half an hour infusion. You can extend the infusion. So you give the fluids a little bit slowly in these patients. As Dr. Pratibha mentioned, that we reduce the dose of carfilzomib. So generally the starting dose is 20 milligram and day one, day two is 27 milligram per meter square. And then generally we switch to weekly regimen of the most accepted dose of carfilzomib is 56 milligram per meter square per week. So even people have used the dose up to 70 milligram per meter square, but the most accepted dose where we feel that the maximum benefit happens is 56 milligram per meter square per week. And if you want to give twice weekly, then obviously it is, uh, from 27 to 36 milligram per meter square. Okay. Can we go to the next question? What are the three key patient education points before starting lenalidomide in an Indian context?
Sir, sir, we have to counsel the if patient is female patient or we have to counsel regarding the fertility, and then counseling the prophylaxis and counseling the side effects and inform about the dosage and the timing.
So your all answers are correct, but you would do all these things for whether the patient is receiving lenalidomide, bortezomib, or any drug. You would counsel about all these things. Now, what is, I think the question here meant is that what is a specific point patient education when you want to give lenalidomide? Specific to lenalidomide. Okay, so what we have seen in the experience is, even though in the Western literature, the dose of lenalidomide mentioned is 25 milligram from day 1 to day 21. But we have seen in Indian patients, they don't tolerate 25 milligram, and many physicians feel that a starting dose of 10 milligram or 15 milligram, if you are using upfront, is good enough in the first month or in the first 2 months. And then if the patient is able to tolerate, then you goes to 25 milligram. If you are giving as a first line therapy, when you are using lenalidomide as a second line or a third line therapy, then generally the dosages used are 10 milligram or 15 milligram, not more than that, because one of the common side effects of lenalidomide is, what is the common side effect of lenalidomide?
Is there a bone marrow suppression generally causes
Yes.
the
Bone suppression and thrombone.
Yeah, myelosuppression is
myelosuppression?
one of the thing. So the another thing which I want to correct, Dr. Nihanthy, is that as you go from thalidomide to lenalidomide to pomalidomide, your immunomodulatory action goes down and your myelosuppressive action goes up. That means the thalidomide you can still use if the patient has neutropenia, patient has thrombocytopenia. Okay, in the cytopenias, some myeloma patients have cytopenias. So in the cytopenias, what are the drugs which you can use? Let's say myeloma patient has cytopenias. What are the drugs which you can use? Thalidomide, I have already said. What are the other drugs?
Uh, so we can use so bortezomib we can use.
Bortezomib will cause severe thrombocytopenia.
Okay.
One of the side effect of bortezomib is thrombocytopenia, and that was also one of the reason why it was changed from day 1, 4, 8, 11 to weekly regimen, and the dose was reduced. There's a lot of work on bortezomib-induced thrombocytopenia. So bortezomib will still cause thrombocytopenia. Anything else?
So steroids we can still
Steroids, yes. So steroids are one which you can use even if the patient is cytopenic. One more drug which you can use. One antibody which you can use.
so daratumab.
Yeah, daratumumab.
Daratumab.
Daratumumab is one. So these are the three commonly used drugs if the patient is cytopenic, you can use. So let's say some myeloma patients present with pancytopenia. It's a rare presentation. Rare means around 10 to 15% patients can have severe thrombocytopenia or leukopenia at presentation. So here actually you would use high dose steroids for the first 1 to 2 weeks before actually going on to using a bortezomib lenalidomide based regimen. Okay, so these are the things. So what I was talking about was, as you go to the next generation of immunomodulatory drug, like from thalidomide to lenalidomide to pomalidomide, your myelosuppression goes up. So pomalidomide has more myelosuppression than lenalidomide. Okay, and your immunomodulatory action goes down. And that is why during the last decade in 2008 or 2009, 2010, when we still did not have too many drugs for myeloma, people were combining thalidomide with pomalidomide. In fact, there is a published paper in American Journal of Hematology where people have used both thalidomide and pomalidomide together. Okay, to get the immunomodulatory action also and to get a myelosuppressive action or the myeloma action of the pomalidomide. Okay, so in this question, there are three key points education. One is the dose modification. The second is obviously DVT prophylaxis. And the third is the skin reaction. I don't know whether you mentioned about that or not. So lenalidomide is very also notorious for, skin reactions. Many patients will start complaining of itching and rash. And again, you sometimes you have to stop the drug in these patients. Okay, so these are the three education points which you need to consider when you are giving lenalidomide. Can we go to the next question? Name two drugs in myeloma that need anticoagulation during treatment. I think this is already answered. You have mentioned about lenalidomide. Bortezomib alone, if you are giving, there is no need for an anticoagulation. And when you are considering anticoagulation in myeloma patient, you have to do a risk stratification of the patient. And the risk stratification means that can you tell me whether myeloma is common in patients who have lower BMI or high BMI?
So
Body
the
mass
B,
index.
so the
Body
BMI,
mass index. Yeah.
so patients with so high BMI.
Yes. So myeloma and MUGUS is more common in patients with obesity. So if patient is obese, that is also a risk factor for
Yes.
thrombosis. So you
And a
have to
lot
do a
of
full, you
So
have
a
to do
lot
a
of time they present with pathological fractures and vertebral compression, so they are already bed bound. So that also adds to a lack of mobility, also adds to a risk of thrombosis. So that
exactly.
is also not.
So exactly. So that means you have to do a complete risk stratification of the patient. You also have to see, at 60 years of age, many patients will have diabetes and hypertension and coronary disease. So they may be receiving aspirin, clopidogrel for that. And you have to do a full risk stratification of the patient when you are considering giving anticoagulation to them. But particularly if you're giving lenalidomide, okay, lenalidomide is one drug where you have to consider giving at least aspirin, even if the patient is receiving maintenance therapy with lenalidomide. Okay, and the other drug, what is the other drug? Where it is kind of a mandatory.
So steroids are also considered a risk. They are also considered prothrombotic. So
Okay,
steroids.
so very good. So let's say the patient is only on dexamethasone, only on dexamethasone. What is the risk of DVT? What is the risk of thrombosis?
So, so I think 4 to 5%.
Okay, you are close to that, 3%. So what is the risk of thrombosis if the patient is only on lenalidomide?
So that is much higher, 15 to 20%.
No, so it is again, 10% or so. But when you combine dexamethasone with lenalidomide, the risk goes to 18% or so. So almost then 1 in 5 patients develop thrombosis. And myeloma as such is a hypercoagulant state because of increased immunoglobulin levels. And we always consider hyperviscosity, although it is more common in Waldenström macroglobulinemia because of IgM, but myeloma also is a hypercoagulable state. So that is why many physicians consider giving aspirin to many of these patients, even if they are not receiving lenalidomide or carfilzomib. The second drug, okay, was carfilzomib, but as I said before, obesity and many of the other risk factor you would consider when you are giving anticoagulation to these patients. Okay, can we go to the next question? A 62-year-old patient with relapsed multiple myeloma started on lenalidomide and dexamethasone. After 2 cycles, they developed grade 3 neutropenia. What is your next step?
Uh, Sir, in this patient, since this is an already relapsed case, so he has a history of pre-treatment, I would like to introduce a novel agent like anti-CD38 monoclonal antibody daratumab. It will not have an effect on neutropenia as well. And we can go with Dara and just Dexa, Dara Dexa, or along with that Bortezomib if the patient uh, uh, not bortezomib. Bortezomib causes thrombocytopenia. Dara and Dexa, so we can use in this patient. Or if the patient is having some baseline renal dysfunction since he's 62-year-old, then we can also use melphalan in this patient, sir, along with dexamethasone.
No, 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 no. Here, it's so no. The first thing here would be that if some patient is developing grade 3 neutropenia, what is the most common cause here?
lenalidomide, sir.
Drug-induced lenalidomide.
Yeah, it is drug
Stop
induced.
the,
So yeah, so you would decrease the dose or you would stop lenalidomide for the time being,
Great.
depending,
Stop.
and then you would evaluate the patient whether he requires a third drug or not. Don't jump on giving any other drug. First is if the side effect is happening because of the drug, you need to take care of that drug. And you have to find out whether we can still, you have to fine tune. So this is a clinical point. You have to fine tune the dose of lenalidomide. And you already mentioned if the patient has renal failure, maybe, you know, if the dose received is 15 milligram would be higher or even 10 milligram would be higher in this patient and they are likely to develop suppression because of lenalidomide. So you would reduce the dose to 5 milligram daily or 5 milligram alternate day. But yes, if the patient is his disease is going up, the embed is going up, then you would consider adding a third agent, which you rightly said daratumumab can be considered or thalidomide can be considered, but not melphalan. Melphalan again is an alkylator. Okay, melphalan again is a cytotoxic, stem cell toxic, and that is why patients who are planned for transplant, you don't give melphalan to them upfront. Okay, because these can cause stem cell toxic.
It's a toxicity.
Okay, we can go to the next question. A patient is started on daratumumab. They now require an urgent RBC transfusion. The blood bank reports difficult cross-matching. What might be causing this and how will you manage it?
sir, myeloma cell it is the daratumumab is the anti-monoclonal antibody against CD38 and RBC is having the also having the CD38. So it causes the false Coombs test, indirect Coombs test is positive. So you have to do the cross matching and blood grouping before giving the daratumumab. If we forget to do that or we sit that, then that in that scenario we ask the blood bank that the patient is on daratumumab. Then there is some specific DTT used RBCs are there. If that not available, you can use the ABO or RSD negative blood groups. Non-cross matched ABO RSD negative blood group.
Yes, so exactly right. So before giving daratumumab, it is always good idea to do send the sample to the blood bank and ask them that this patient is will be receiving daratumumab, so they will do a cross match. Otherwise, once the patient is on daratumumab, then it is very difficult to cross match the blood of these patients, and you have to wash the RBCs. And DTT is one agent which can help in that. Okay, so always, you know, as a checklist before giving daratumumab, it is good idea to do a cross match and on and a blood grouping. Okay, next question. How much time do we have? Sorry, can somebody tell?
So we have 15 more minutes to go, sir.
Okay, up to 4 p.m. Okay. Okay, question 8. What is the difference in neuropathy risk between bortezomib, carfilzomib, and ixazomib? We have covered that. I think bortezomib has the maximum risk. And for that, to decrease the risk, we give subcutaneous. Carfilzomib and ixazomib have a lower risk of neuropathy. We can go to the next question. Name 2 myeloma drugs that can cause interstitial lung disease or pneumonia. Okay, this is a
Sir,
tough one. Yeah.
sir, I think isatuximab is one.
Isatuximab.
I think ma'am
Why
had
should
mentioned
isatuximab cause?
it.
Sir, it is the ADC belantamab mafodotin. It sometimes causes ILD.
So I'm not sure because I have not made these questions, but to my mind, I'll tell you, I feel the 2 drugs which can cause is one is bortezomib, the other is immunomodulatory drugs. When bortezomib was launched in 2003, at that time I think it was 2007, a paper was published in the journal Blood from Japan, where they said they actually saw a lot of patients developing interstitial pneumonia because of bortezomib. So that was the first study which was published in 2007 in Blood, saying that bortezomib causes interstitial pneumonia. Although, if you ask me practically, we have not seen so many patients, but yes, we do have seen some patients who come with pneumonia. And since most of these patients are on triplet therapy with lenalidomide and bortezomib and dexamethasone, so it is very difficult to say which drug has caused interstitial pneumonia. So in my mind, it is one is bortezomib, and the second should be a immunomodulatory drug
So
like yeah.
elotuzumab also, as per ma'am's presentation, SLAM7 inhibitor elotuzumab is also said to cause ILD.
Okay,
With
we
your
can ask
permission,
Dr.
can I intervene here, sir?
Yeah, sure,
Just
sure, sure.
quick comment.
Please, most welcome.
So Dr. Pratibha, what you are saying, those are the drugs which most of us have not used. But as Pankaj was saying, bortezomib one, definitely you should remember IMIDs, because we have had 3 cases of patients having a drug-induced interstitial lung disease. This is particularly those patients who are on maintenance with IMIDs, particularly. 2 were with lenalidomide and 1 patient had it with thalidomide, because many of our patients still are on thal maintenance, particularly those previous patients who used to be earlier treated with thal. We are continuing then on thal. And as soon as we withdrew the drug, the patients had improved. So we could show a correlation with the drug exposure and withdrawal. And then we reviewed the literature. So IMIDs definitely, bortezomib definitely, as Pankaj said, and daratumumab. We had 1 patient of DARA-induced ILD. So we have a very aggressive respiratory department, pulmonology department with us. So this ILD, we also saw 1 patient monoclonal antibody, that is daratumumab. So we reviewed these 3 literatures. So probably the 2 myeloma drugs that they are looking at here is BOTI and IMIDs, but also the DARA is known to lead to a ILD-like of situation. So,
Yeah,
sir, thank you, sir.
Uday.
Pankaj, sir, sorry for
Yeah.
interjecting.
No,
Sir.
no, no. Thank you so much for the feedback, because these questions are made by Dr. Nihanthy, and I'm just posting this question. Even I do not know what is the next question. So based on the so it is actually I'm also learning here. So I learned that even DARA can cause interstitial pneumonia. Okay, good. Next question. What hydration precautions are needed for carfilzomib or versus ixazomib? I think we have already discussed that before giving carfilzomib, it is good idea to do a saline loading of these patients, but you have to be careful, because one of the side effect of carfilzomib is hypertension. So patient, you need to monitor the blood pressure of these patients. And if you're doing a saline loading, obviously the blood pressure can also go up and the patient can develop cardiac failure because of that also. So you have to be very careful when you have to do a loading, but you also have to be careful. We can go to the next question. What are the key differences between daratumumab and isatuximab, as both are anti-CD38 substrates? Okay, this is an important question, although I feel isatuximab is not available, but yes, as a theory part of it, you should know about.
Sir, daratumumab is an IgG kappa anti-CD38 monoclonal antibody.
Both are
Isatuximab
anti, both are, I think, IgG kappa.
Isatuximab is IgG1 kappa anti-CD38. So I think that is
I
one
think here
difference.
I think the question which Dr. Nihanthy want to ask is in the mechanism of action or in the probably in the outcome. That is why this question is made. Key differences.
Okay.
I think so both are CD38, but I think as far as my knowledge goes, even in the CD38, the substrates are different. So which basically means that even if you have used daratumumab, and you can use isatuximab post daratumumab, and in the mechanism of action, I think daratumumab causes bond formation and killing of the cells, whereas isatuximab causes ADCC type of a reaction. I'm not sure. Uday or
Sir,
Nihanthy, do you
yes,
have
sir.
anything?
Yes, sir. Sir, I'll quickly wrap up that answer. So basically, when the DARA combines with CD38, so there is something known as a catalytic site and non-catalytic site. So the isatuximab binding is partially encompasses the CD38 catalytic site, whereas daratumumab binds to a site totally outside the catalytic site. So because of this, the apoptosis induction, the enzymatic inhibition, and Fc gamma related mediated effector functions are different between the two. But the clinical relevance to this is that if a patient is refractory to DARA, ISA can still be given, as Pankaj sir just told now. So that's what, see, all these mechanisms and the basic pathophysiologies are relevant for the bedside application. So what Pankaj sir brought out, that DARA refractory patients, if ISA is available in market or you have a hands-on to ISA, you can still go ahead and give isatuximab in these patients. But the vice versa, generally people say does not work.
Yes,
I
thanks.
want to add on something also, sir. So the binding site or the epitope of both the CD38, even though both the immunoglobulins are IgG1 kappa only, the binding epitope is different for DARA and IXA, sir. DARA is a partial inhibitor, whereas IXA is a strong inhibition. So even if patient progresses on DARA, in future you can re-challenge with IXA. So that was the only thing I wanted to get in here, sir. And one more thing, DARA can be used IV and subcutaneous also, whereas IXA currently only IV data is available, no subcutaneous differences.
Yeah. Okay. Thank you so much, Uday and Dr. Nihanthy, for this feedback. Uh, Next is you plan to start is yeah, we can go to the no, we can go to the question 12. Yeah. What does DTT do? Why this is relevant? I think we have covered this. We can go to the next question. A patient on lenalidomide maintenance post-transplant present with a new papular skin rash. We have discussed this. How do you differentiate between manageable rash versus one requiring dose adjustment? How would you monitor for secondary malignancies in patients on long-term lenalidomide maintenance? Okay, so yes, although we have discussed about the rash with lenalidomide, but if you want to add something on that, and the last question about the secondary malignancies.
Secondary malignancy like acute leukemia and MDS are common on long-term use. And for the second part, manageable rashes, if it is grade 1 or grade 2, we can still continue. If it is grade 3, then we have to reduce the dose, sir. Hold on, and after back to grade 1, we can adjust with the reduced dose, sir.
Dr. Pratibha, do you want to add or say something?
So secondary, I mean, I don't know if I should be asking a question for a question. I mean, secondary malignancies are going to be more common if we are using an alkylating agent as a prolonged therapy in myeloma, or even with lenalidomide. We can see a good, I mean, good proportion of secondary malignancies.
I think when we talk about lenalidomide, patient on lenalidomide, and we talk of secondary malignancies, these are mostly skin malignancies. When
Okay.
we talk about leukemias and when we talk about other solid, that happens because of alkylator use in the past, as Dr. Santosh already said. But so, when lenalidomide was used as a maintenance therapy in 2012 to 2016, there was a lot of literature and people, there were a lot of papers coming up with secondary malignancies, and almost in all the papers, this was mentioned 7%, 10%, 12% of risk of secondary malignancies, and mostly it was the skin malignancies which happen in the West, not mostly in India. But we do see patients with leukemia, and that we feel is because of the patient receiving alkylators like cyclophosphamide and melphalan in the past, either as part of conditioning regimen for transplant or otherwise. So I think this is what is meant by this. About the rash, I feel that the best thing is to stop lenalidomide, and then you can try introducing a lower dose, like starting for a 5 milligram. But even then, there would be some patients who will develop a rash again. So sometimes you have to stop lenalidomide and you have to consider alternative immunomodulated drug like thalidomide or pomalidomide in these patients. So unless you don't have any choice of using any other immunomodulated drug, then probably you can try desensitization, but I think most myeloma physicians actually go to either thalidomide or pomalidomide in this situation. Okay, next question. 66-year-old on Dara Len Dexa develops worsening fatigue and new macrocytic anemia. Okay, macrocytic anemia on Dara Len Dexa. Yes.
Absolutely water and why? How will you manage?
Even okay. So Santosh, Pratibha, anything?
Sir, I think we should go for a peripheral smear CBC and Coombs test in these. And
See, patient on Dara would be positive, likely. No? Macrocytic anemia. So
so pan agglutination maybe is happening because of that. It is reflecting a macro setting.
So
IMC.
again, as I said before, Dr. Nihanthy has made this question, so I would also have to guess. Probably uh, anemia sometimes happen on daratumumab, and fatigue also is one of the side effect of daratumumab. That I'm sure. I think macrocytic anemia I have not seen many, but probably I would hear related to use of daratumumab only because of some hemolysis, unless some patient has B12 deficiency or folic acid deficiency, which obviously would be entirely different. Or if I say far-fetched kind of imagination, the patient is developing malabsorption and then developing macrocytic anemia. I don't know. Dr. Nihanti, what is the answer here? I don't know.
All your answers are correct, sir. It's mainly because lenalidomide causes vitamin B12 and folate levels also. So the similar way, and daratumab again causes Coombs test positivity and hemolysis. So both of them needs to be kept into consideration. It can either be because of dara or len. So that's why it may be a biopsy to be done. You were right, so you explained everything. So I need not add anything.
Okay, thank you. Thank you. So I'm also giving my viva here.
I'm learning, sir. Actually, it's
Okay, thank you for making this question. Next question, please. Okay, why should all multiple myeloma patients in India be evaluated for B12 and folate deficiency before initiating immediate therapy? So, okay, that explains the previous question. 60, okay. But I think the first question is very relevant. Why should all myeloma patients in India be evaluated for B12 and folate deficiency?
Because sir, they are vegetarians. I mean, Indians are supposed to be mostly considered vegetarian, so they have a pre-existing deficiency, and then we start them on lens. So maybe that will exacerbate the deficiency.
Okay, Dr. Santosh.
Sir, I already ma'am told कि IMIDs causes the macrocytic anemia by depleting vitamin B12 and folate. If before starting IMID, we should rule out whether there is a pre-existing macrocytic anemia or not. Like causes like hypothyroidism causes the macrocytic anemia, vitamin and nutritional status causes the macrocytic anemia. So before that, we have to rule out that so that we can differentiate that it is due to the drug or it was the pre-existing there.
Okay, good. So I would add here a little bit. One is that even though Dr. Pratibha mentioned that we are vegetarian, but I can tell you that even in non-vegetarian, the B12 deficiency is common in India. And there are many studies. In fact, some epidemiological studies suggest up to 60% of patients can have B12 deficiency. And uh, and the one of the reason, in spite of taking non-vegetarian diet, patient having B12 deficiency is because of our gut microbiota and the problem with the absorption. So, so that is one thing which we need to keep in mind. And as Dr. Santosh was discussing about something, he mentioned about hypothyroidism. I think that again is a very important thing. Patient on immunomodulatory drugs are also, we need to do a thyroid function test in them at least once a year, especially patient on lenalidomide maintenance. And that can also be responsible for macrocytic anemia. So in the last question, we mentioned about macrocytic anemia. I think hypothyroidism is also one of the cause for that. And the third thing is, if you have any patient who has in whom you are diagnosing multiple myeloma based on only on anemia, let's say the patient does not have any other CRAB features except anemia, then before you label the patient as active myeloma, I think if the patient has B12 deficiency or folic acid deficiency or iron deficiency, we need to correct that before initiating treatment for multiple myeloma in these patients. Obviously, patients with renal failure or cord compression or hypercalcemia would require therapy immediately. But I believe the patient coming with anemia alone, you can wait for these tests, and only if you have ruled out these deficiencies, then you can label the patient having CRAB criteria or the A part of CRAB in these patients, and then start treatment for myeloma. Okay, the second part of question 15 is 66-year-old diabetic multiple myeloma patient from Kolkata on bortezomib, what formulation and schedule? I think we have discussed about that it is to be used subcutaneous and weekly. Can we go to the next question? Okay, we are done. Very good, very good. So
I just
we
have
have discussed.
one
Yeah,
doubt.
please. Yeah,
Ma'am,
please.
the last question you mentioned specifically Kolkata. Like, are we missing something here, or like there is some reason for that? Because
Nothing in
I would definitely need to know that.
No, they do say that in some of the places, like, the chances of, especially in obesity and dehydration, you're giving some imid or anything, which, most of the patients need to have good hydration. And also, that's the only precaution. Otherwise, there was nothing specific. Okay.
Okay.
Thank you so much. And I also enjoyed and I also learned a lot from the presentation as well as the interacting. Although I have only two students, I would actually suggest if there is a possibility of interaction with all other people who are listening to this discussion would be very useful for future. Thank you so much.
Thank you, sir.
Thank you, sir.
Thank you, sir. Thank you, ma'am.
Uday sir, any last comments from your side, sir?
No, thank you. Thanks a lot. It's always pleasure listening to Pankaj. So we keep learning, and he has been my teacher, my mentor, my guide, philosopher. So thanks for a co-sessions today. And I also have a NEJM perspective writer, Dr. Nihanthy here. So thanks, Nihanthy. That was nice article in NEJM, but at the same time, today nice presentation and also good questions that you have framed. So we could all discuss it very actively.
Apologies for any mistakes or anything. I'm really sorry in between for that.
No, not at all. It was
Learning
all
for me, sir, actually, more than, I don't know, I could go in depth. And actually, it was a great learning interacting with Pankaj sir, you, and especially Hamza sir also, sir.
So I thank again the E-Gurukul for this, and if Pravas sir is there online, thanks Pravas sir for giving us this opportunity, and thanks Karan. So on behalf of me and Pankaj sir, we'd like to thank on behalf of even Indian Myeloma Academic Group and all the students who are here. It would be nice if they could join our monthly journal clubs. Their fundamentals about myeloma would get further cleared, and great opportunities to win prizes in that. So, in fact, recently Karan had won the Eagle Eye competition nationally and had a beautiful presentation. So, I would invite all of you to join that as well. Thank you.
Thank you so much, sir. Thank you, Pankaj sir, for taking out time on a Sunday afternoon. I mean, it's a bit asking you a lot, but then I think this was very fruitful for our students and residents. So thank you so much, Uday sir. Thank you, Dr. Nihanthy, for the beautiful presentation. With that, I would also want you to come and join us on the next Sunday for drugs in myeloid neoplasms, where we have Dr. Prashant Mehta as examiner, and we have Dr. Ramesh, who would be the speaker for that session, and Dr. Stalin would be the moderator, and Dr. Fahima, who would be the subject mentor. So with that, I would like to end this session, and thank you all for joining.
Thank you.
Thank you. Thank you so much.